Just as a disclosure, I always think it's good to know people's biases. I don't have any industry bias or funding, but I am certainly an academician, editor-in-chief of the Journal of Academic Emergency Medicine. Developed a series there called Evidence-Based Diagnostics, which is really my passion, because that's what we do in emergency medicine. We work in making diagnoses. Once we know what the diagnosis is, as Al said this morning, we do a great job of caring for patients. But patients don't come in with the diagnosis stamped on their head. They come in with a constellation of symptoms. And it's our job to filter through lots of patients with lots of overlapping symptoms and trying to figure out what's going on that brought you here today. And that's why I created that series. It's a bugaboo for all of us that in the United States we're seeing 6 million chest pain patients per year that get admitted at a cost of $10 to $11 billion per year. We know that most of them are going to do fine. We know that most of them aren't going to, that it's not acute coronary syndrome, and it's not going to have a cardiac event in the next 30 days. But the trick is which ones, and how can we start to minimize some of the variability in practice safely and get the right patients into the hospital and into the hands of the cardiologist and send the rest home for further outpatient evaluation appropriately. There's nothing like acute chest pain to really kick your ego in the butt, right? I remember when I was a chief resident of internal medicine and emergency medicine in Pittsburgh. I'd been a doctor, a diving medical officer in the Navy before that, so my sixth year of residency, and I was working moonlighting in Beaver, Pennsylvania, home of Joe Namath, and a 90-year-old farmer came in, and what's wrong, sir? Hurts right there, the tip of his left pinky. And I'm starting to evaluate him and talk to him. No way thinking cardiac. And then the charge nurse hands me the EKG from triage, and he's got an anterior wall MI, a STEMI. And so that quickly took me down a couple notches in my level of confidence and made me really think hard about every patient that I see and thinking about really life-threatening diagnoses, even with the most vague chief complaint. So how do we do that? So I wrote this chapter that you have in front of you, and it's got a lot of material on it. So we're going to try and get through that in the next 25 minutes or so, leave you some time for questions. The most important aspects of this chapter that I hope you'll bring home with you are that heart score on page 97, really useful tool, and I'm going to try to paint the literature picture for you of how we know that now. And then page 107, you've got this chest pain decision aid that we'll talk about at the end. Shared decision making is a really hot topic right now. We had at Academic Emergency Medicine a conference 3 years ago trying to understand the science of it in emergency medicine and how to move forward. This chest pain decision aid really represents the gold standard of how to do this and how it can help our patients and how it can help us. So focus on those two things, and if you take nothing else from this chapter, take those home with you when you go back to your shops. So the heart score, why am I so high on it? Well, this first abstract starts to look at if theoretically we could have an instrument that had 98% sensitivity to diagnose all of those patients who are going to have within 30 days a major adverse cardiac event. That is an NSTEMI, an MI, a revascularization event where they had to go to the cath lab or get a cabbage, or death, cardiac death or all-cause death. How do we predict those patients? Which instruments are going to give us 98% sensitivity? And they looked at the TIMI score, which was really never developed for the ED. It was developed for the critical care units in the hospital. They looked at the Goldman score, one of the first clinical decision instruments ever. And they looked at the heart score. And they said, we want it to be 98% sensitive at finding those patients who are going to have a bad outcome. And we want to be able to send 30% of our patients home, at least. Where's the threshold with those instruments that you can do that? And they found that with the TIMI score, a score of 0 did that. The Goldman score less than 2 did that. And a heart score less than 4 was able to achieve that in this first study. So can that be replicated? The second paper looks at the heart score and another decision instrument for chest pain, the North American Chest Pain Rule, and they found that suitable for early discharge, how many patients does it identify that you can send home? 13% with the heart score, 20% with the North American Chest Pain Rule, and 4% just using your Gestalt. Raman talked about many decision aids don't really compare it to what we already know, what we do every day with our experience. Well, compared to Gestalt, in this study, we're only able to send 4% of patients home, where if you use the heart score, it'd be 13%. And then the heart score looked like it did not do quite as well as the North American Chest Pain Rule. But if you look at the reclassification, the ones that went from high risk to low risk or low risk to high risk, The heart score did so more accurately than the North American rule, about 1 in 5 cases. So it looks like it's probably the better rule in this study as well. And then I talked about my passion is diagnostics. And I just want to spend 1 minute talking through the science of diagnostics. And this goes for diagnostic tests like a blood test, troponin, or a clinical decision instrument. First, the lowest level of evidence that we can get to is that we can measure something. We can measure the troponin in the blood. And if you can't do that, you can't have a diagnostic test. The next level is that new test that you can now measure, that molecule or the decision instrument, can stratify some group of patients into high risk or low risk, whatever your diagnosis is. If you can't do that, it's not going to help us. The next level is this instrument that now can distinguish patients, high risk or low risk, or disease positive, disease negative, can actually identify a subset of patients that I couldn't identify before with whatever the standard care was, my gestalt, or with the previous diagnostic lab test that I have, or the imaging test. There's a new, in this Venn diagram, subset of patients that I wasn't accurately diagnosing before, using whatever measure I can for the gold standard. And then the next level is this new subset of patients that I can identify that I couldn't before because of this new test, actually have some intervention that I can put upon them that's going to improve their outcomes. Because if I can identify them, but I can't do anything about it, does it matter? Is that a big deal? And then the next level is, it's more of a societal view, that if I can identify this new subset of patients that I can do something about, is it going to be $1 million per case to make an improved outcome for that patient? And if so, is that something insurers are going to pay for? Is that something society is going to pay for? And unfortunately, most diagnostic tests, most clinical decision rules, they never get to those levels of evidence. We pretty much get to the level of can distinguish disease positive, disease negative, and then we stop and we say ready to go. And what I'm going to walk you through with these next few papers on the heart score is how it does start to understand how it does really help us, how it helps us in the ED with our flow, how it helps our patients with their confidence that this is the right path for me, and how it helps with the cost and the test ordering. So abstract number 3 is a cluster randomized study in the Netherlands. That's where the heart score was derived. 9 EDs, about 3,500 patients. And what they found was that there was, in this randomized trial, so half of them getting standard care and half of them getting the heart score that I just told you is a pretty good rule. No difference in mortality, so appears safe, but also no decrease in admission rates, so it didn't change how many patients got admitted. No decrease in the ED length of stay, so it didn't save a lot of time, and there did not appear to be a significant cost savings. There was about a €200 per patient savings favoring the heart pathway, but that was not statistically significant. So it appears safe, but may not have the desired outcomes that we want. Of note, though, in the pathway that was randomized to the heart score, 18% of the physicians deviated from that and ignored the heart score. So this next paper, number 4, actually looks at how frequently does that occur, where the physicians actually are asked to use the heart score and then just deviate from it. And they found that similar to the Dutch study, 1 in 5 cases deviated from that heart score. The physician ignored it. Not saying there's a good reason or a bad reason for them to ignore it, just that they had the score and it was given to them, but then they didn't use it. And in not using it, that was associated with over-testing in about 29% of patients. That is, more testing was done than the heart score was indicated was necessary. And there's under-testing, so patients who should have had more testing because they were higher risk on the heart score, in 13%. So you can see how the heart score can start to standardize practice and get the right care to the right patient. Not just less testing for everybody, but the right testing for the right patients. That's what the heart score can do. And they hypothesized that if the heart score had been adhered to in this abstract number 4, 7% discharge rate increase. We would have been able to send 7% more patients home. So abstract number 5 is from Wake Forest here in the United States. And they found that, different than the Dutch abstract, number 3, that there was a significant decrease in the ED length of stay when the heart score was used in the United States. Probably had something to do with the fact that their control arm, the ones who didn't get the heart score, spent 22 hours either in the department or in the ED ops unit. The Dutch study had been about 4.5 hours. So in their study, the Wake Forest study, you use the heart score, you get out of the department in about 9.5 hours. If you use standard care, you get out of the department in about 22 hours. So you cut it in half by using the heart score in the United States. Abstract number 6 and 7. So we got this instrument. How well do cardiologists and emergency physicians agree looking at the same patient using the heart score? Because that's a conversation we're going to be having on the phone with our cardiologist consultants. That's abstract number 6. And bear in mind, these are cardiologists looking retrospectively at these results. So who do you think they're going to trust? The cardiologist's interpretation or the emergency physician's interpretation? Probably their own, the cardiologist. And what they found was that there was discordance or disagreement between emergency medicine and the cardiologist in 10 out of the 33 cases that they looked at. And the discordance was almost always that the cardiologist said this patient's low risk and the emergency physician said this patient's high risk. 9 out of 10 times, that's what happened when they disagreed. And where did they disagree? It wasn't on the EKG, and it wasn't on the patient's risk factors of the heart score. It was on the history, the gestalt. You walk in the room, you look at the patient, and is this an MI or not? Am I really worried about this patient based on what they're telling me is the character and what made their chest pain come on? Who do you think sees more of those patients? I don't have cardiologists in my department. They don't come down and see the patient acutely, unless it's a STEMI. We've got a nice pathway for them. But we see the chest pain patients, the undifferentiated chest pain patients. So I would probably err on the side of saying we are the experts in emergency medicine of seeing these patients because we see a lot more of them. But nonetheless, there's some disagreement. So you got to bear that in mind when you start talking to your cardiologist about this heart score, is that there's not going to be uniformity, particularly in that area of the history when you walk in and look at the patient. So how do we do within our specialty, within emergency medicine? This abstract number 7 is a chart review of 19 emergency physicians who did the heart score on the same patients. And they found that physicians who have less than 5 years experience are more likely to admit low-risk patients. Probably they saw that same 90-year-old with the pinky pain that I saw. And the ones who are more senior physicians, they have more likelihood to rate the same patient as higher risk based upon their more years of experience, but they're also more likely to send the lowest patients home. So we can look at the same patients at different levels of experience and have different scores, even within emergency medicine. And you can see where the trends fall based on levels of experience with this one. So a lot of my colleagues will just ask me, well, what's the point of doing all this work to stratify these patients? It's putting me out on a limb. The lawyers are going to say that you should, whatever the patient is, you should have admitted that patient. The retrospectoscope is always perfect, right? And so why don't we just admit all of them? That's what the lawyers make it sound like we should do. Is there any harm in admitting these patients? Is there a value added to admitting patients? And so abstract number 8 is a retrospective review of 11,000 admissions over a 5-year period in 3 EDs, patients with chest pain who had unremarkable or unchanged EKGs and 2 negative troponins several hours apart. And they looked at the rate of major adverse cardiac events at 30 days. The frequency of that happening, 0.18%, with a pretty narrow confidence intervals. This is a big sample size. So a very rare event, far less than 1%. It's even smaller than that though, because if you exclude the ones who were, when they were in the department, had some ischemic change on their EKG, a flip T wave, or a nonspecific ST depression in one lead, or abnormal vital signs, the event rate of a major adverse cardiac event fell to 0.06%. So that equates to, you'd have to admit 1,667 patients to capture one patient with that event at 30 days. And there's nothing that says admitting that patient, those patients would prevent that event. We don't know that. Just to capture the patient that had those events at 30 days, you'd have to admit over 1,600 patients based upon the event rate in this study of 11,000 patients. So pretty small effect size for admitting patients very generously. This abstract number 9 is an Australian study, and they didn't have an ops unit there. So their standard practice was you do the history and physical, EKG, 2 troponins, and then you send the patient home. And they wanted to know what their event rate was. Are the Americans right when they admit so many of these patients, or should we be continuing what we're doing in Australia? And they found that they had an event rate of far less than 1% as well, just like this previous study, abstract number 8. They had 5 out of 18 patients with an NSTEMI or unstable angina who in the ED had an abnormal EKG or had a trope that was elevated, but the patient left AMA anyway. Those 5 are included in there. So the event rate then, if you take those 5 out, who should have been admitted, who's recommended by the ED physician to bring in, was 13 out of 18 patients. So they think their approach is pretty good. Lots of patients, very small event rate in Australia, even a smaller event rate in America because we admit so many of these patients. So what is the value of admitting the patients then? I said that you had to admit 1,600 patients to capture those patients. What's the value of keeping them in the hospital? This next abstract, number 10, starts to look at that. And it looks at, first of all, in this abstract, what do patients and physicians think? What do they think the value of staying in the hospital is? Patients believe that if you go home, your event rate, a major adverse cardiac event at 30 days is 80%. 8 out of 10 patients you send home are going to have one of those events. If you stay in the hospital, it drops to 10%. That's patients' just belief in this study. The providers, the physicians, they think if you stay in the hospital, the event rate is 10% as well. So the physicians think it's way high just as much, which may explain some of the reluctance of using the heart score and sending more of these patients home, if physicians have that underlying belief that the event rate is that high. So abstract number 11, telemetry. This is a daily battle in my shop. The telemetry beds are always short, and there's a belief, particularly among the hospitalists and some of the cardiologists, that we need to put more of these patients on telemetry if we're going to keep them in the hospital. We don't have telemetry beds, so they end up ruling out in the emergency department and getting most of their work up, waiting for half a day to a day in our department, tying up beds. This abstract number 11 was an AAEM clinical practice committee evaluation of all the literature on the topic of telemetry, 12 papers total, and they found that low-risk chest pain patients, as defined by little benefit, as defined by absence of EKG changes, cardiac exam showing no pulmonary edema, no elevation in the troponin, and no worsening of the chest pain while they're in the department, all pretty straightforward stuff. Those patients don't benefit from being on telemetry. So the problem is that most of our hospitalists and cardiology colleagues aren't reading the AAEM clinical policies. So this is a discussion I personally have to have over and over again in St. Louis. And I work in our community hospital as well. And the cardiologists there, it's equally hard to get them to not put all these patients on telemetry beds if I'm bringing them in for chest pain. But just bear in mind that if we are going to admit some patients, they don't all need to be on telemetry, and that there are some guidelines out there as to which patients are most likely to benefit from telemetry monitoring. So then let's transition now to provocative testing. The nuclear stress test, the stress echoes, exercise tolerance testing. What's the value of those? We tend to hang our hat on those quite a bit, particularly if we're sending these patients home. So abstract number 12 notes that the American Heart Association in 2014 recommended that if you're sending these chest pain patients home, they should have provocative testing within 72 hours. And so, not surprisingly, between 1993 and 2001, if you look at Medicare patients, there was a threefold increase in the use of these provocative cardiac tests. AHA recommendations translated into more testing being done. And downstream from those provocative tests, the rates of angioplasty increased twofold, and the rates of putting the stent in increased sevenfold. So a lot more testing downstream. Every test that we order has some downstream ramifications for the future stakeholders who see that patient, who see the test results. And there's a response that we've got to do something about it. If you order a test, something is abnormal, patients are worried about that, families worried about it, we're probably worried about it. You've got to do something about that abnormality. That's what this data is showing. Notably, there's no evidence that all of those interventions, all those stents that were put in, all those casts that were done, changed outcomes at all. The cardiac mortality did not go down. The rate of missed MIs in the ED didn't go down. So a lot more testing and little measurable benefit, according to this data. Abstract number 13 is a single center review in an ops unit. And they noted that in stress testing in their ops unit, 11% of the patients had abnormal stress tests, but 74% of those were discharged home anyway. So we kept them in the ops unit, probably got a couple of tropes, and then got the stress test result, and then it was abnormal, and then we ignored it in 3 out of 4 cases and sent the patient home. And when the subset that actually went to the cath lab, when you look at those, that half of those showed that the stress test results were false positive, that there was no coronary vascular disease on the cath. And the ones that did have a lesion that was amenable to putting a stent in or some cardiac revascularization, 0.7%. So that equates to a number needed to treat to do a stress test on these patients of about 143 to find one that has some coronary lesion that you put a stent in. Not a terrible high number needed to treat, but certainly higher than most of us would think. It's interesting to note in this study as well that the patients who had intermediate risk scores, they used the Framingham score, not the Hart score, they had a much higher rule-in rate when you did the stress test and then went to the follow-up cath, than that 77% ruled in than the high-risk patients. So intermediate risk patients seem to be a higher risk category than the high-risk patients, at least when you stratify them by the Framingham score. Framingham score, high-risk patients had a 15% rule-in rate, 1.5. So just bear in mind that intermediate risk group is pretty high risk group according to this study. Abstract number 14. What about exercise tolerance testing? I'm sorry, what about if you move the stress test availability to the emergency department? Is that going to increase our ED efficiency? Probably. It kind of makes sense that if I don't have to keep the patient waiting for cardiology's stress test unit to be available, that it's going to save some time. And this study confirms that, particularly on the weekends. You probably have the same scenario as I do, where the stress lab is closed on the weekends or at least on Sundays. So these patients who come in with chest pain late Friday night or Saturday have to wait till Monday to get their stress test if I'm relying on cardiology. What these guys did was that they moved this, they had the capability of doing the stress test in the ED, and they actually saved, they decreased their length of stay from 3 days to 1 day by having that available in the ED. That was almost always weekend and holiday stress tests. Not surprising. There's also no deaths or complications from the treadmill test down in the ED, showing that the ED can probably do this just as well as cardiology with appropriate preparation and training. Abstract number 15 is a British Columbia study looking at outpatient stress testing after you do an EKG that's non-diagnostic, and then you have two troponins that are non-elevated anywhere between 2 and 6 hours apart. And they showed that about 1% of the patients ended up having acute coronary syndrome on stress testing at 48 hours, and that there's no cases of missed ACS. There's a lot of patients who we recommend stress testing to. So you got chest pain, nothing showing acute coronary syndrome here in the ED today. You need to follow up and within a couple days to get a stress test as an outpatient. Talk to the primary care physician. A lot of those patients don't follow up. No surprise, right? A lot of my patients in inner city St. Louis don't have a primary care physician for me to talk to or for them to follow up with. And so this study showed that a lot of them, even in this Canadian healthcare system, don't follow up when you tell them to. But when they do, only about 1% rule in for acute coronary syndrome, so still pretty low event rate. So this next one, number 16, exercise tolerance testing. Has its day passed? Should we be just looking at nuclear stress test and stress echoes? And so what number 16 shows is that exercise stress tests, the day may have passed. As far as diagnosing acute coronary syndrome today, the range of sensitivities they quote is 23% to 100%, so huge variability in sensitivity. Specificity, equally huge range of 17% to 100%. However, the exercise tolerance test, as you know, is a functional test. The other tests are physiological tests. This one does have the benefit of showing, of predicting 5-year cardiac mortality. So as a prognostic tool, the exercise tolerance test probably has some value and probably is not something we should necessarily throw in the garbage if we can find the right patients upon who to test. So now these next few abstracts really opens Pandora's box. It gets into coronary CTs. Who has access to coronary CTs in their department? Any fans out there of the people that have them? Do you like them? Do you not like them? Not like them? Not like them? Okay. Yeah, you got to give the beta blockers if they're not. Yep. So I think a lot of those really low risk patients, outpatient would be fine if you can have outpatient follow-up. My center at WashU, just to be honest, we were one of the centers that was in the original New England Journal study that showed that coronary CT is accurate and does benefit patients. My fear is, though, as a diagnostician, a person who studies this, is slippery slope. Just like happened with PE, where we start testing every patient who comes in who's a no risk for acute coronary syndrome, not a low risk, but a no risk. And truly, if you're worried about acute coronary syndrome and they're low risk, and you have a completely clean coronary CT, I can see the value. You've given your patients some reassurance, the physician's reassured. This is not atheroscleromatous obstructive coronary disease. No argument there. The problem is that there's a radiation exposure that goes along with that CT. There is incidentalomas. You've probably seen those that have them, where you've got the lung mass of something that probably is not cancer. Nothing suspicious about cancer, but now I've got to tell my patient that you've got a node there in your lung which is going to need some follow-up. in 6 months, and they're going to be worrying about that for at least 6 months. And some of them are going to go to get that biopsy. Some surgeon will want to biopsy it, and there's going to be harm associated with that additional downstream diagnostic workup. None of these studies look at that. They don't look at those downstream effects of overdiagnosis and over-testing, or the costs. So let's look at what it does show, though. Abstract number 17. This is a study of about 200 low-risk chest pain patients. 119 of them had exercise stress tests. 71 had CT coronary angiograms, and about 5% were abnormal between the two studies. Number 18 looks at chest CT to try to get at that 36% who actually don't follow up and do any testing that you recommend. Can you truncate that by doing the testing with CT in the emergency department? And this showed that you could. So abstract number 18 looked at cases that had CT coronary angio and cases that didn't when you had suspected acute coronary syndrome. And they say that it has value in this study because 14 of the 15 patients that had the CT showed obstructive coronary disease, and one of the 50 controls did not find that. So they're saying they found it in these ones that had the CT, didn't find it in the others. Who knows whether greater than 50% coronary occlusion is clinically significant? That's what their definition was in the study, or if anybody did anything about it, or if when you put whatever you did about it, put a stent in, or do an angioplasty or do a bypass surgery, whether that improved the patient's outcome or quality of life, don't know. All we know is that the CT showed the lesions, that the standard approach did not. Abstract number 19 looked at low to intermediate risk chest pain patients randomized to get CT coronary angio or routine care, and they found that in 83% of cases, the CT was negative, showing clean coronaries, and it decreased the ED length of stay by 7 hours and diagnosed 5.5% more patients with coronary disease that you miss by standard care. Abstract number 20. They analyzed post-ED visits and cardiac testing between CT coronary angiogram and routine care, and they found that there was no increase or decrease in revisits, so it didn't really prevent patients from coming back, and it did not increase downstream cardiac testing as well, which is warming to my heart. But again, they don't really contemplate the other potential harms of over-testing using the CT modality. Abstract 21 is a counter to number 20. This is out of the Mayo group. And they actually show that the number of CT coronary angios between 2006 and 2013 increased from 0.8% to 4.5% of ED chest pain visits. Huge increase in how much it was used. And that the CT coronary patients were more likely within 6 months to undergo percutaneous interventions, to undergo CABG, and to have stress tests. So it did lead to more downstream testing. And that they're also more likely to be hospitalized at 30 days. My guess is, just trying to put this together, you do the CT, you find some 30 or 40% lesion, you communicate that to the patient. Now they're worried every time they have a little chest pain or indigestion, they come back to the ED. And they're going to continue to come back to the ED indefinitely, probably, because you told them you found something on the CT coronary. No difference in this number 21 with 30-day acute myocardial infarction mortality. Did not decrease deaths. So with all those potential negative effects, did not decrease mortality. Okay, so last couple abstracts, we're going to look at the role of shared decision-making. Our society has this technological tenesmus, this feeling that technology is always better than what's between our ears, that the physician cannot do as well as the imaging test. Number 22 is not looking at cardiac studies. This is just looking at testing in general with some expensive new technology. And what you can extrapolate from this, what you can extrapolate from this, looking at back pain, looking at patients with other chronic pain syndromes, is that knowing more, doing more diagnostic testing, more expensive testing, didn't make patients more reassured, didn't decrease their worrying, and didn't decrease ED revisit rates or downstream testing. So a bit of an illusion that this expensive testing, CT coronary angiogram, decreases patients from coming back, according to that study. And then number 23 is work out of Mayo again, shared decision-making instrument. I know it's great to talk about shared decision-making, but it's much harder to do in my experience in most conditions than people would indicate when you stand up in front of a lecture hall like this. These guys at Mayo put together this instrument. They had patient representatives, they had artists, they went through literally 100 different versions of this to figure out what gets the most information to the patients in a way that the patients like, and that brings the diagnostic options in alignment with the patient priorities. And this is what you have in front of you. You can look at it yourself. Let me know if you have any questions about it. But using this instrument in this randomized control trial, reduced admission rates by 15%, reduced 30-day cardiac testing by 8%, reduced patients' decisional conflict, that they're feeling that they're not sure what to do and the doctor didn't help them to be more sure what to do, and it didn't increase deaths or 30-day adverse outcomes. So it did appear to work. So that's it for low-risk chest pain. Sorry I went a couple minutes over my time. The fire alarm certainly helped. Please let me know if you have any questions, and I think we're at break now. Thank you.